Can everybody see? Yes, okay. Okay, so I'm going to talk about the impact of substance use disorder in early childhood and really hit on some key factors that we can do to help have some protective factors and build protective factors within the substance use disorder population. And for any of you who have seen any of my presentations on early childhood, I always start with attachment because everything starts from the beginning. And this is my favorite definition of attachment because it's a deep, enduring emotional bond that connects one person to another across time and space. And I think that that's so key because we talk a lot, and I know a lot of women, you know, when you're working in pregnancy and postpartum, a lot of women identify how critical that period is within the first 3 years. And we all know that that is a critical period for attachment. However, it still takes place across time and space. And so, you know, that key attachment is important for so many different factors, but it can happen over time and it can evolve. It can be a little more difficult, but it can happen. Prenatal attachment is beneficial. And so, especially for our pregnant women we work with, I really promote that positivity during pregnancy. And for pregnant people, once their rates and rhythms become in sync with the babies, it reduces needs. So if you notice in the second trimester, for some women who get sick in the first trimester, in the second trimester, some of that sickness starts to reduce. And that's more as the rate and rhythm start to pick up too. And so that's nice to see that some of the needs can decrease. Prenatal attachment is linked to positive postnatal development. So we see a lot of that. And negative associations during the prenatal period really is linked to symptoms of anxiety and depression, not only in women, but within those infants as well. And so they feel some of that stress as well. I always like to hit this component because when we think of those early attachments, we automatically go to mom and baby. And so I just want to put in a shout out to dads, because dads are really important. We try to involve dads as much as possible. And other partners too. And a lot of the times when I show this slide, you know, a lot of people will ask me about same-sex partners, and there's a lot that shows that key core attachment can come, but there is something with the male involvement that really impacts development. And so a lot of it comes from kind of the rough and tumble play and the different thought processes that help regulate emotions in a different way than what women can, because our brains are different. And so fathers definitely do have an impact, and there's tons of literature that shows it does reduce aggression within kids. They're more likely to manage their emotions better and progress academically. And so dads definitely do matter, but I know we talk a lot about moms and connecting those babies. So secure attachment is important. We know that it hits a lot of different areas. It builds that self-reliance. It makes people feel confident in themselves, who they are, which allows them to be more persistent within tasks, cooperating with others, building that empathy, and having that social competence, right? Those interactions are so really important, and we need that. And we see a lot of those struggles in kids today. Kids in daycare are getting kicked out because they can't really play with one another. They're not feeling sorry about it, right? Some of them are really struggling in taking some initiative and tasks. And so we do see a lot of this today, and can't help but think how their attachment is going. So we know the developing brain needs so much, right? And so like we talked about, within that first 3 years, it's really key. It's really important to get those basic needs met: communication, relationship, and stimulation. Babies are born with all of the neurons they'll ever need, right? But they need those neurons to fire and wire together. So we need those neuroreceptors to be firing and wiring together to hold on to them as they grow older. And this is how they do that. They do it through getting their basic needs met. So clothing, food, shelter, that communication, and knowing that they're communicating. And the way that babies know that they're communicating is they cry, they scream, they fuss, and then they get a response from that, right? So this is called the serve and return. They need to get that response for that brain development to continue, because if they don't get that response, then their body's going to keep trying to figure out how to get these needs met. And so then their brain development isn't really continuing at that point. Now, all of their neurological energy is going towards getting just those basic needs met. And so we want to make sure that they know that they're communicating effectively. And this also helps build relationships, right? Kids love it when they can eat and be held and cuddle. And so that's exactly how they know that they're being taken care of and that they're loved, is because they're getting those needs met. They're not having to stress, right? So their sympathetic nerve system is staying calm, and your sympathetic nerve system is your fight, flight, or freeze. And everybody has that. And then your parasympathetic is more of that relaxation. And there's a lot that's linked to it, including your GI system. And I know we have a lot of patients that talk about their babies having GI issues. And sometimes it's because that parasympathetic nervous system isn't quite able to calm down. So we got to get that flight, fight, or freeze under control. And many of the times we have to work with the parents in order to help the babies do that too. So stimulation too, so just stimulating baby's brain, talking to them, narrating, playing with kids, being involved. And so it's still that serve and return. You know, they're putting out and we're responding. So let's add a substance use disorder on top of all of this brain development. And sometimes it can have a really big impact. We know that parents are already struggling with, this brain disease, that now they have to work to build this reward system on their own. So this substance use sometimes gives like an overflow of that reward system. And so now parents have to kind of build that reward system on their own. And many of the times, this can impact their ability to regulate their own emotions. And so when we have kids that are needing to get some emotional regulation and their parents are dysregulated, it can kind of throw those emotions off. And so we really work with parents on learning to regulate their own emotions. But we have to remember that their physical brain structure at this point is a little off. So we need to help with some of that and be patient with that. We know that recovery is an ongoing process, not only for an individual, but the entire family. So this is a parallel process for the entire family. If you think about it, you think about the stages of like denial. So when an individual is in denial and like, well, I'm not really sure I have a problem. If you think about it, there's someone in the family that usually says that too. I don't think it's a problem. I think they only like do every now and then. They really don't have the money or the time, or I don't see it, right? So you kind of see this in that parallel process. The change is a big piece for a lot of our families that we work with. And when you're doing family work, this is one of the biggest pieces because from a crisis comes change. And many of the times they're experiencing crisis in this. So it's like change, crisis, change. But in this stage, what happens is, especially when there's kids involved, kids memorize patterns of interaction. That's how they live. That's how they get their needs met. That's how they feel safe, secure. And when parents start to go into recovery, they change their patterns of interaction. Even though it is for the best, it's a healthy pattern of interaction. Kids, especially kids 5 and under, don't really know that. So what they know of their whole world is now changing. So then you'll see an increase in behaviors. And this is not very rewarding as a parent. It's really difficult to manage some of these behaviors. And so a lot of the times, this feeds into that parallel process because now the parent kind of feels like a failure. They've already been involved with a substance use disorder, maybe had their kids taken from them, and now they can't even be a parent, right? Like, so some of these thoughts start to come into their heads. And this is where they're trying to change it. And sometimes kids can make it very difficult with all of those behaviors. So this is where they need a lot of support and understanding that and knowing that and really reflecting. A lot of parents like to hear that they're not the same person experiencing this. And so the group therapy is really beneficial for this, as they can process with one another and understand that they're not the only one going through this, but really promoting it through that change. Because kids, what they like to do and unintentionally. I mean, I always say kids like to manipulate, and it's their job to manipulate us as parents. But what they like to do is when they feel that tension building, they like to push parents to the point where there's no more tension. And sometimes that's to the point of, a possible reoccurrence. I had one family that I worked with, and the little boy, he was 5, and he not in words, but he through processing, he really identified that he liked pushing his mom to the point where she would leave for a couple days, have a reoccurrence, and come back because she felt better. Things were better. It all felt better. And so we had to change that pattern of interaction. And so it takes a lot. But it's an ongoing process, and pregnant persons are really highly motivated. Pregnant moms tend to be younger. They have more support. They're not as far in their disease, so they're not as far in the substance use disorder. So a lot of the times they're ready to work. They're motivated. So they're really a great population to work with towards recovery. However, we know that a lot of women we work with do have complex trauma. And so it can be really hard because trauma is linked to that emotional attunement. And that's really can be triggering. And it's really important for baby's brain development. So it's like a teeter-totter, right? Like it's up and down all the time. And so we know that some of this trauma can hit, and it can hit hard. And there's a lot of the times there's the caregiver betrayal that we talk about with women with substance use disorder and trauma is, a lot of the times we see women who lose their kids to kinship care or foster care. And so then it's a parent or an aunt or somebody taking over at that point. And a lot of our pregnant persons feel betrayed by that caregiver because they're now caring for them, or they're trying to take them away, or, whatever the situation might be. So there's a lot of trauma that can be triggered. And especially if they didn't have that parental caring when they grow up. We know that there's a lot of risk factors for families in recovery, impaired attachments, economic hardships, supports or lack of supports and healthy supports, legal problems, and emotional distress. And so these are all risk factors. That's really hard. It's a lot of involvement. I always tell my parenting moms that I don't know how they do it and maintain jobs. And I mean, we've talked about that here before. It's a lot that they put into it. It's a lot of work. And so but some of that can be high risk factors for them too. And it's important because disrupted early attachment really can affect affect and regulation, social competence, increase of aggressive behavior, decrease in learning, later psychopathology. And it's actually one of the toxic stress that comes from that disrupted attachment is very triggering for parents. And that toxic stress is high with substance use disorder. It's even higher with postpartum depression. And sometimes we see women that have both. And so the risk factors are kind of doubled for them and their babies and their children. So really helping them understand that, preparing for that, and things that they can do around that, because it has a huge impact. So when we look at building healthy brains, it has a huge impact. If you look at the brain on the right, so this is a baby's brain from an orphanage that had very little interaction. And so postpartum depression and substance use disorder sometimes can look like very little interaction with babies, right? Sometimes they can be present physically, but not present mentally stimulating. And so this is kind of what that does to the baby's brain is it kind of shuts down some of those areas in the frontal lobe. And the frontal lobe is the areas that we make decisions and where we process things a little bit more. And you see even the red areas where they're really stimulated, that's the emotional piece. And so you can see they even have higher emotional pieces. So higher sensitivity to some of those emotional pieces that happen. happen. So when we see kids who are coming from homes where they've had a disrupted attachment or a substance use disorder, they always express like high emotions, like they're really extreme with their emotions. And yeah, because their brains are wired that way, right? And they're going to respond that way, and they just can't stop. You can change some of that. And that's the great thing about the brain, is there's tons of neuroplasticity. So this isn't end all be all. You can change some of that. And so that's the nice piece, but it does have a huge impact. And sometimes it just needs a little bit of help. So this is one of the quotes that I like to put in. I needed someone to love me when I could not love myself. This helped me love my baby more. This is actually in regards to one of our nurses. So the mother was saying that the nurse was really supportive of her, and she just needed that nurse to love her when she couldn't love herself at that moment. And this really helped her love her baby a little bit more. So coming from more of a caring, relational, competent framework is really beneficial. So having that caring component, being relational and interactive and asking questions, but also if you don't understand, become culturally competent of the population you're working with. And especially this population, there's so much going on and so many layers of this onion that we want to make sure that we're helping when we're peeling back, so that we're not tearing while we're peeling. So how can providers help? Talking about checking in with yourself, providing compassionate care, explore and build, and help parents remain emotionally attuned. So you want to help them kind of reflect. Checking in with yourself, identify what feelings you bring to that situation, authentically engage. I mean, we've hit this before, especially with this population. If you're not authentic, they'll know it from a mile away and be done with you. So authentically engage. Tell them you don't know or you don't understand, or you're going to find out if you don't know a situation. What does your body language say? A lot of, if you go back to the slide where 80% of women are dealing with complex trauma who have a substance use disorder, you know, people who have complex trauma, they have a hypervigilance. And so sometimes they're aware of your emotions before you're aware. And so they sense it by body language, interactions, tension. So if your body language is off, they're probably going to sense it really fast. And so just being aware of your body language, what you're bringing, build a trusting relationship. Positive thoughts promote positive interactions. I had a couple staff members at one point where I used to work who would come and talk about this family negatively every time. And I was like, okay, let's process through this, because while you should have a safe space where you can say some things, if you're talking negatively about a patient or somebody over and over again, you're going to feel that way and think that way, right? And so you want to make sure that you're talking positively. And if you're not, what's going on with you? And that's where you need to reflect and kind of check in with yourself. Reassuring confidentiality is huge. I mean, we talk about the fears that come along with treatment and accessing treatment, and just being from a rural population, and understanding that confidentiality is really important, and reassuring it, especially when it comes to family, right? Because sometimes many of my patients have talked about this, you know, when they're in recovery and they're starting to get back involved with the community, everybody knows everyone and everything, and from schools to the WIC office to everywhere, just reassuring confidentiality so that their information stays safe, and bringing compassion and not consequences, right? Caring instead of these strict rules and consequences. Providing compassionate care, so helping with newborn care and gently. Nobody really likes admitting that they don't know how to parent or be a parent or take care of a child. And especially when there's a fear of losing their child. And so really just providing some of that, breastfeeding and bonding, and how important that is. And even if they choose not to breastfeed, the importance of that skin to skin and what a difference that can make. Mood changes, understanding mood changes, normalizing mood changes right after a baby, right? Doesn't always mean that they're struggling with a substance. There's normal mood changes after having a baby. Poor sleep, the changes in sleep, the sleeping patterns, being aware of that, what it does to individuals when they lose sleep, what it does to kids when they lose sleep, right? So huge piece. Focus shifting from the mom to the baby. So that's where their focus is shifting, and that's where we should be shifting is from the mom to the baby and that dyad then. Loss of insurance. A lot of the times, this is a huge stressor. Parents will lose insurance after they have the baby. And so we talk about how to gain that back, how to gain their own insurance, or how to take advantage of some other programs that are involved with helping them. Financial stressors are always huge, right? Can't find formula, diapers, things are expensive. So some of those financial stressors, I've had some patients who have had some legal problems, and so they can't get a certain amount of assistance. And so then it comes into some serious financial stressors. Cultural mom norms. This is a big one in providing compassionate care and understanding that moms are very different. And a lot of my patients really struggle with wanting to be a normal mom. And we really explore that and reflect upon that and what that even means. Because moms come in all different shapes and sizes, and there's really no normal mom. And a lot of actually what people have reflected on and discussed was kind of what they see on social media and what's put out to them when their kids do have disruptive behaviors in stores, how people respond to them. And so they talk about kind of those norms that they really struggle with. And so we process through some of that. Explore and build. So exploring their sensitivity, where their emotions are, how they're able to manage that, how they parent, right? Like, so how are you parented? How would you like to parent? How do you parent? So really exploring all of that. Parenting from a distance, how to build those relationships from a distance. We talk a lot about this because we have a lot of parents who get only visitation. And so really what they should be focusing on during that visitation. I had one parent that I worked with a lot, and every visitation she would get 2 hours, and she would drive a huge distance just to visit for 2 hours. And the minute she'd get there, she would check her baby head to toe from like bruises and rashes, because she had this extreme guilt that her baby was in foster care to begin with. And so we talked about how to overcome that so that you're there present with your baby instead of focusing on what you've done wrong and, the possible implications of that, but building that connection and relationship. Then also how to advocate yourself when you do feel like there are some of those implications. And so parenting from a distance is huge because we want these parents to be connecting in these little pieces so that they're building that attachment over a long period of time so that when reunification comes, it's not as difficult as it can be. Mend and repair. So we talk about ways to mend and repair the relationship, where their child is developmentally and how to mend and repair that. We have one now that their child's 10, and the mend and repair is a little more difficult, but it's still possible. And so we talk about that and ways to do that and the consistency and how important that is. Kids need to have that consistency and that predictability so that they feel safe and secure, which leads to building those relationships. So building that trusting relationship and building a reflective capacity. So building the capability to reflect on their own emotions and identify how they're truly feeling in that moment, right? That's that emotional attunement, so that then they can be emotionally available for their children. Okay, I'm going to play this video, but you know what? Let me see if you guys can hear it. I don't think I hit that share.
Parents.
Can you hear?
Throughout history, we've struggled to get it right. We hope we won't pass on our emotional issues to our kids, and we swear we won't make the same mistakes our parents did. We all have great intentions, but something seems to get in the way. Let's look at what that might be. At Circle of Security Parenting, we believe that being emotionally available to our children and their needs is the key to doing our best as parents. We call emotional availability being with. It means teaching emotional intelligence by being with our children in all their feelings, like sadness, joy, anger, curiosity, pain, frustration, excitement, and so on. Being with children helps them understand, trust, and move on from feelings. And Knowing someone is with them in their feelings helps children feel less overwhelmed and more secure. Decades of research backs this up. For parents, some of this comes easily, but other times our children express emotions that make us uncomfortable, so we pull away or try to overrule their feelings, which leaves them on their own. We do this because our children's feelings can trigger strong emotions in us. We think of it like this: our history during childhood of how core people responded to our different emotions creates the background music for how we experience our children's feelings. Let's look at this example. This girl and her father have been enjoying time together in the park, but suddenly aware of the time, Dad says, "We need to go." When the girl hears this, she starts crying and gets increasingly angry. All at once, the dad's background music changes. The background music that is playing for the father right now, we call shark music. As it turns out, the dad's own mother was uncomfortable with loud displays of emotion, and she didn't know how to handle them. So throughout his childhood, she repeatedly told her son it was pathetic to cry, and she never ever asked him about his feelings of sadness or anger. His ability to deal with his daughter's emotion now is greatly affected by the experience with his mother there. Shark music. We're rarely aware it's playing, but it's our past experiences telling us to be afraid of or uncomfortable with a feeling or need that is actually safe. When our shark music limits our ability to respond to these feelings, our children learn to hide or feel ashamed of them. This is a problem because we're teaching our children to fear emotions that are actually both safe and essential in life. Most of us experience shark music with one emotion or another, and it's different for everyone. But whenever it is triggered, our ability to respond to our children's needs is limited. The good news is, by simply calling it by name and reflecting on what our children need in the moment, we can turn down our shark music. This is so important because if we can learn to manage our history of negative experiences and perceptions, we can respond to the truth of our child's current situation and be with them in it. Ultimately, this will help our children grow up with a better ability to understand and share more of the emotions they experience. There's no escaping it. Strong feelings are a challenge to manage as parents, but our children always benefit when we have an accurate response to what's happening, rather than reacting to the shark music we're bringing into the relationship. Remember, there's no such thing as perfect parenting, and blame never helped anyone feel more secure. That includes blaming ourselves. But the more often we can identify our shark music, the better off our children will be.
So I love the being with in the, so this is from the Circle of Security, which is, it's actually a group intervention. And it's an amazing intervention, great techniques. I've been trying to bring this to West Virginia for 2 years. They're like super strict about their population, their target population, and like the training process, but we're still going to work at it. But it's a great concept, and I love showing this video in group because parents then we process like what their shark music is, right? And if you think about it, if you're a parent, think about it, like I totally get shark, like defiance is my shark music, like that's where I'm like ready to like eat someone. So yeah, you totally identify that, and it goes back to that emotional regulation and getting individuals to start to emotionally regulate. And even for parents, I mean, I think about it with some of the pregnant parents that I work with, and the trauma that they have, and them not ready to hit some of that trauma. Okay, but let's just touch on where some of this is coming from. And then it makes that trauma not look so scary sometimes if they realize that they can regulate some of their emotions. So it's actually really helpful to motivate towards that too. We want to learn to build resiliency. So, SAMHSA has identified that health, home, purpose, and community really build resiliency, right? Having individuals be able to manage their own health care and focus on their physical health, and having a safe place to live. having a purpose, serving a purpose, right? So conducting a meaningful life. And many of the times parenting is that purpose for them. So helping them serve that purpose. Finding a job is really important for them for some. And so in participating, I have one mom that it's really important for her to participate in like groups. Like she joined like the what is it, the SAD group, like the MOPS, that's what it is. The moms, the toddler mom groups. And so I mean she loves that. She loves buying the candy for it. She loves doing things. It gives her a purpose. And so it serves a purpose, but that builds resiliency. Getting individuals back involved with the community. We talk about people, places, and things, and many of the times individuals with substance use disorder are isolating themselves from people, places, and things because it's healthy for them, but we need to help get them re-involved with people, places, and things that are healthy for them and re-involved in the community. We all know how that feels, right? We all went through this pandemic and know that isolating from the community, it's hard sometimes getting back involved. Sometimes we're ready to jump right in. Sometimes we need to put our toes in the water first and just kind of feel it out. And so it can be really hard for some people. So we want to make sure that we're providing that linkage. So along with those protective factors, specific concrete resources, right? So transportation, housing, food, those are important. That's part of that health. Strengthening the support system, that's part of their home. So building that support system, emotionally and psychological resilience. So getting them involved with the services that are necessary, parenting education, tips, courses, support groups. This is really beneficial. Understanding the child's social, emotional, and cognitive capacities and development. I found this one really beneficial. I do this a lot in group because you go to the pediatrician and they tell you like the milestones your kids are going to be at or should be at. But they don't really talk about that social emotional development a whole lot. And so a lot of the times, if you don't know it, how would you know to ask some of those questions? So we really explore that. And then this is just one of my favorite pictures that I always show. So that hormone lighting up is oxytocin, right? It's the love hormone. And so you see how much it serves the mother as it does the child, right? We know that it builds babies' brains, but it also builds the mother's brain too. And so it's really, really significant and important. Any questions?
Well, first and foremost, thank you as always, Amanda. You always do such a wonderful job presenting.
Thank you.
Any questions, comments, Laura?
Just a quick question. Thanks, Amanda.
Yeah.
So in your work with specifically with pregnant or recently postpartum women and the whole idea of attachment, can you talk a little bit about the role that parental guilt and shame play in mom's ability to connect and attach with their infants?
Yeah, so that's a huge barrier. I think that every mom that I've worked with substance use disorder holds that. I've had one mom in my history really work completely through it. It's so strong and they hold on to it. And we do an activity. I do an activity. I have these little like blocks that they hold on to as tight as they can for like 20 minutes. And we talk about like and we start going through it. And after like 20 minutes, like some of them will change hands. And I'm like, what are you doing? You have to hold it in the same hand. And they're like, I can't, it's hurting. And so we talk about how they're holding on to that parental guilt and how much it hurts and starts to hurt other places and some things you do to overcompensate and what you try to do to create relief, but it's really still there. And so we talk about how important it is to do that for that attachment. And so, and like I was talking about that one mom that, she would go to those visits and that was that parental guilt that she would just review her baby head to toe. Right. And so we talked about really staying present and being in that moment. And that's why that reflective capacity is so really important to reflect on those emotions and to be able to explore that parental guilt. Because as you know, sometimes parents are not willing to go there. Like, I'm not ready to talk about that. Like, I've done so much to them. I can't even think about it right now. And the more they process, the better. But it is, and it really creates a lot of damage.
I've also seen like when kids hit toddler age, parents are sometimes they don't want to set limits or
Yes.
be mean, you know, or dole out a punishment because like it's like, I've already hurt my child enough. I
Yep.
don't want to cry or upset.
Yeah, so they're really permissive and sometimes overcompensate in other areas, right? Or buying things. You'll see them overboard on Christmas or birthdays. And so we really talk about that and staying within the limits. And I think that that's really important because it does come about. And I think the other thing that comes about in toddler ages, because that parental guilt comes in, that maybe they got their kids back and then they're like, I feel guilty for not wanting them around or for being stressed out about them. And absolutely, it's a normal feeling to feel stressed out or not want to be around your kid. That's a total normal feeling, right? So normalizing some of those emotions again, because it is really difficult, and that parental guilt will really hold strong. And sometimes it definitely stigmatizes, and it definitely creates a problem even accessing care at times.
Yeah, I'd like to add too that where I see parental guilt coming as well is with mothers who use substances or who've been on medication assisted treatment during pregnancy, and sometimes over pathologizing behaviors during toddlers. They're afraid if I did this to them, this is my fault why they're acting this way. It's like they're two. That's why they're acting this way.
Yeah, so I think anytime, I think that's a really great point, Jen. So I think anytime we can provide some of that guidance on typical development and social emotional development and where they should be, I agree with you 100%. I get calls all the time like, there's something wrong with my kid. Here's what's going on. I'm like, that's pretty age appropriate, right? So really providing some anticipatory guidance on developmental stages can be very beneficial. We actually hit some of that in our group. Like, we'll provide some education on each age range so that they know what to expect with some of the normal behaviors or typical behaviors, so that they're not feeling like, oh my gosh, there's something wrong with my kid. Yeah. Good points, good questions.
I don't want to move too quickly past questions. Anybody who was kind of waiting for their turn want to go ahead and ask a question?
And you're always welcome to chat in as well, and we're happy to read it out loud.
Well, thank you, everyone.
Yeah, thank you all so much. And thank you, Lauren, Dr. Price as well for the questions and comments. Anything else? Amanda, any final comments you had? All right. Sounds good. Well, as always, please do submit a case. It doesn't have to be a full-on case or anything. It can be a question or maybe an interesting patient situation that you encountered and just want to share with the group. That always is a great way to spark discussion and prompt cases in the future. Laura, I noticed you unmuted.
Yeah, I didn't know if we could ask if anyone wanted to impromptu kind of share a case at all now while we have a little bit of time.
Absolutely. And Dr. Baltier, I see you put your video and audio on. So floor is yours.
Yeah, I can do one. Actually, it's pretty not interesting. It's just bringing it to people's attention. Maybe it's more like, and get some perspective. So we had I'm going to make up the number since I don't have it in front of me, but say 28-year-old gravida 2 para 0, who I got a call from her OB provider, an obstetrician, who said, can you take her into your MCOTE group? And so I said, sure, it's always, yes, we can. And as I looked at in her history, she had been to the emergency department. We have a bridging program at Berkeley Medical Center here. So she'd gone into the emergency department and was told to start Suboxone. And so the emergency department obliged, which is great, got somebody into treatment, got her 3 to 7 days of buprenorphine started, did their assessment, etc. as I looked more into it, she's actually a patient with a history of osteosarcoma, cancer survivor with partial amputation or total amputation, and had been on chronic pain medicines, morphine, long acting, and then some short acting medication as well, appropriately, and had been managed on that. So her pain doctor wasn't completely comfortable handling it on a pregnant patient because of that, but they were willing to continue. She went and saw a maternal fetal medicine specialist who gave her the impression that the standard of care is to be on buprenorphine, and told her that, the patient heard, and this is where it's a little bit murky, that she should switch over. So the patient spent 3 to 4 days just emotionally struggling with this. She'd been on this. She really did not feel she had an addiction problem, but in order to do the best for her baby, she would do what was needed, and presented herself to the emergency department. At the time I saw her, she was already on Suboxone, had been switched over for about a week. And so we had a very interesting discussion. She actually doesn't meet the diagnosis of opiate use disorder or any substance use disorder. She's a chronic pain patient with appropriate use of her chronic pain medication, whether it could be managed differently, better, etc. So we actually agreed, she agreed to follow our treatment plan as if she had opiate use disorder. She was now dependent on Suboxone, so not appropriate to take her off of that. And she was having good pain relief. And she's been in our group now for 3 weeks and actually found it very useful connecting with other women, even though, many of our patients say, I'm not like that, but she does have a different issue. But she's found it quite useful, especially since being on Suboxone, she'll have to deal with CPS, whether there be any concerns or not. So the statutes kind of really limit what we do. So that's where we are with her. Just wondering what people's input on that is. She was very reluctant and scared at first to join a group of women with opiate use disorder, but they all have welcomed her, and she's actually done quite well over the last couple of weeks with that.
So I'll just mention that we've had that issue at Marshall a couple of times where people have not had a lot of the lifestyle risk factors when they've become pregnant and needed to be maintained on a medication for opioid use disorder during pregnancy to reduce risk for the fetus. And we've really just tried to take an individualized treatment approach. It sounds like that's similar with this patient, that maybe to validate that there maybe are some ways in which your situation is different, but because there are common things that she will need to learn anyway, CPS, breastfeeding guidelines, all of that stuff, that maybe those would be great groups for her to attend. What we've done at times, depending on how long the person, whether the person ever actually did fully meet criteria or how long a period of stability they've had prior to coming to our program, we've offered to do a greater number of individuals, so they didn't have to come to every single group. For folks who maybe had very long period of recovery in a kind of more of a traditional mat setting, say 8 years of very pro-social lifestyle, and then just by chance, we're in a group with a lot of folks very early on, experiencing some visible signs of being very early recovery, and that was triggering for them. We've kind of worked around substituting some of their hours. So I think that's great that she is getting that benefit. But I also, when there's a case that's maybe, 1 out of 100 of your patients, I think it's good to go ahead and individualize their care. I don't see anything wrong with that.
And what was a little frustrating is, so if I had been taking care of her, I would have just continued her medication. That would have been completely appropriate. But you're right, exactly. She's really benefited from some of the other things, because chances are, even on chronic pain medicine, a CPS report would be made. She'd have to deal with that, and it would be a bigger shock at delivery than at the time of that. But it's also kind of expanding to our, medical community that, not every pregnant woman needs to be on Suboxone. Methadone's still a valid treatment. And if it's chronic pain, that's still, one's not better. I think the support is real important. And so she's done well, but I've, we've had some people that now their drug of choice is buprenorphine. And so it's kind of evolving, definitely.
We've definitely seen an increase in providers willing to continue to prescribe or to treat women when they become pregnant. Unfortunately, we've not seen them also provide some of the psychoeducation that we provide during groups in our specialty program. So kind of wish, I'm glad that they're able to be treated in a less restrictive environment, but really wish some of the highlights would still be available for them.
Janine, was there something you wanted to comment on?
Yeah, I mean, it just occurs to me, and I would love to hear from the group that, Dr. Baltiera, and sounds like what, Dr. Price and that we're doing down at Marshall is sort of adjusting to these individual patients. And I'm wondering, do we need to look at the system? Is the system really meeting the needs of these chronic pain patients? And do we need to be doing work at the state level to, because I've heard this for years when I first started this work, where as soon as a woman got pregnant, their chronic pain doctors would just discharge them from care. And then I know different groups or treatment programs have been able to pick them up. But, that seems to me a failure of sort of our system, as opposed to, individually, what's best for that patient? I mean, why should she be treated as someone who has an opioid use disorder if she does not have one, right? So I'm just curious what others think.
Yeah, so Janine, I agree. We're forced to put people in a box. And so if you even look at it, my prescribing this medication to this woman, is a stretch of the regulations. It's patients aren't boxes. So we do need to, at the same time, on the other end of the spectrum, as I was explaining to this patient, sometimes it's, the medication or drug you're using isn't the risk, it's the social risk, and you may still have those risks. And so Child Protective Services or whatever support agencies should be involved. And I have a problem with their very quick turnaround of yes, no, you're in, you're not, you're in, you're not, you're in, you're not. And they really do it that way. And it's staffing, it's all those other things. But we really don't have a system that provides support for these families antenatally or postnatally even. It's really a check and they're checking to see extreme cases. I would have no problem with some of our families being supported for 6-12 months easily, not removing children from the home, but just providing support during that time. And I don't think we have the resources or have not dedicated those resources. So I do think we need to kind of advocate, there's a bigger understanding. It's not black and white. It's and many women are coming to us. Another case I had, I got a call from, again, our inpatient. They said, can you start this woman on buprenorphine? I'm serious. How far along is she? She delivered yesterday. I'm like, she'd been taking buprenorphine on her own, had been seen by providers, but nobody thought to refer her. I mean, she was buying it off the street illicitly, or is now not buying off the street, but she's been purchasing buprenorphine, which is what she is. But she definitely could use support, and she's, again, done well. And we actually were able to do a video consult and get her started right away. But again, somebody who doesn't fit into that traditional box.
Well, I'll just put in my plug, although I think nearly everyone on this call has heard me say this before. We absolutely need some reform to our state policy for reporting of prenatal substance exposure. I'll also kind of tie us back to something that Amanda was discussing about really maybe you didn't use this term, but I translated it in my mind to trauma-informed practice, that we need to realize that just even the process of delivering under these circumstances where they'll be greatly scrutinized and challenged as to whether they should be even allowed to parent. Yeah, this is inherently traumatizing for people, but also people who statistically are much more likely to have already had a diagnosable trauma even prior to that, and that how we talk to patients, how we offer services has a lot to do with whether they're going to feel comfortable to accept those. I had a case come to mind immediately when Amanda was describing kind of the impact of trauma on our adult patients, on our parenting patients, that I had a day that was not even a bad day, and I felt I was keeping a very neutral face. And this particular patient I know has disclosed to me her history of trauma, and she's very attuned to any slight change in your facial expression. She was the only person that day to stop me and say, "Are you okay?" And I was thinking like, oh, I did not realize that our patient population, have a really high rate of trauma, and they pick up on those things. And so if someone is resentfully handing them a referral form in the delivery room, they're going to pick up on those things.
That's so true. And, if moms don't believe they can be good parents, they can't be good parents. And so if we, that's what they hear during their prenatal care, and when they deliver, then we've already set up that family for failure. And so, absolutely.
And I feel like sometimes, I think that's a really good point, because I feel like I've heard so many of my patients say like, I have to be good at parenting, right? I'm not good at anything else. I've done all of these other bad things. And then unfortunately they get these difficult babies, or sometimes then toddlers who have these behaviors, and they totally internalize it, and it becomes a rejection cycle, and it just feeds into that. It's hard.
We have a few minutes left. Any other questions or comments kind of related to today's discussion? Well, I may say this frequently, but we are all open to any discussions. If you think of questions after the call's over that you'd like us to discuss next month, please reach out. You can either reach out to our invitation, you can reply back. Those are monitored emails, but I'll also put my email address in the chat. And I'll kind of hand things back over to Mitra to close us off.
Awesome. Thank you so much, Dr. Price. As always, like you said, feel free to reach out with any questions about the cases and any topic requests that you might have. We're always open to that as well. So just shoot us an email. The only announcement that I have is that the next session will be on September 12th, and Dr. Jennifer Price will be presenting on transitions of care for postpartum women with SUD. So keep an eye out for that reminder. Thank you all so much for joining, and we hope to see you guys next time. Take care.